Two people came into the cardiology ward. One of them was 25-year-old Darren, who came in with a fever, chills, and fatigue. On the clinical examination, his fingernails had splinter hemorrhages, and the palm of his hands had some erythematous flat lesions. There were also some track marks on his forearm. The other one is 75-year-old Anna, who also had a fever and the same splinter hemorrhages and erythematous flat lesions that we previously saw. On auscultation, a heart murmur was heard. On her history, she said she was at the dentist 2 weeks ago. Okay, so both people likely have endocarditis or inflammation of the inner layer of the heart. Remember that the heart's wall is made up of 3 layers, the epicardium being the outermost layer, then the myocardium, and the endocardium, which is the layer that gets inflamed. The inflammation can affect the heart valves, the mural endocardium, or even prosthetic valves. The most common cases of endocarditis are due to microbial infection, and this is called infective endocarditis, but in some cases, endocarditis can also be non-infective. For non-infective endocarditis, the first step is usually damage to the endocardium. Damage exposes the underlying collagen and tissue factor, which causes platelets and fibrin to adhere, which forms tiny blood clots. This is called non-bacterial thrombotic endocarditis, or NBTE. Tiny clots and fibrin can develop into vegetation, especially on the heart valves, which damages them and makes it harder for them to open or close. Although the exact cause of NBTE is unknown, it's thought that a pro-inflammatory state where cytokine levels are elevated can increase clot formation. This can happen with hypercoagulable states like when there's a malignancy, especially pancreatic adenocarcinoma. Another situation where NBTE can happen is with systemic lupus erythematosus. This is an autoimmune disease involving antigen-antibody complexes, and in this case, they settle in the endocardium and cause inflammation, leading to a particular type of endocarditis called Liebman-Sachs endocarditis. Remember that it's associated with large vegetations, sometimes described as verrucous vegetations, since they look like warts. Now, infective endocarditis occurs when pathogens find their way to the endocardium, typically from the heart valves. Every day, there are opportunities for pathogens like bacteria and fungi to get into the bloodstream, but this is not a problem because they're usually few in number and can be easily cleared by our immune system. However, sometimes a larger quantity of microbes can get into the bloodstream, like if a person has an obvious open wound or an abscess during a dental or surgical procedure or via use of infected needles. These microbes can float around in the blood for long enough to reach the heart. A particular site that's prone to infections is the heart valve, which is supplied by tiny blood vessels. Now, most often, the valves on the left side are the ones affected, the most common being the mitral valve, and then the aortic valve. This is sometimes due to predisposing conditions, with the most common one in some countries being mitral valve prolapse, and less often with the bicuspid aortic valves. So, on these valves, bacterial colonies, clots, and fibrin can also form vegetations. They usually present on the mitral or aortic valve, but what's special here is that they can present on either surface of the valve, though most commonly on the undersurface. Let's now go over the microbes that can cause endocarditis. Viridin streptococci, especially Streptococcus sanguinis, is the most common cause. They have low virulence, are found in the mouth, and they typically only affect valves that have had some previous damage. So think older patients or those with a history of heart valve disease after a dental procedure. That's because Strep sanguinis uses special molecules on its surface, called dextrins, that bind to fibrin-plated aggregates on damaged heart valves. This usually results in small vegetations which don't destroy the valve. Staphylococcus aureus, on the other hand, it's a highly virulent bacteria that can be found on the skin, and it can infect damaged valves. They're often introduced via surgical procedures, wounds, or intravenous drug use, and often affects the tricuspid valve. S. aureus causes large vegetations that can destroy the valves. Next, we have Staphylococcus epidermidis. A high-yield fact here is that the bacteria loves foreign prosthetic material, like prosthetic heart valves, and this could be your best clue on a test. This bacteria is usually introduced into the body at the time of heart valve surgery, and it literally creates an extracellular matrix around itself called biofilm, which allows it to stick around on the valve. Another common point of entry into the body is through an infected intravenous catheter. Enterococcus is a part of the normal urogenital flora, but following genitourinary catheterization or surgery, it can escape into the bloodstream and go on to cause enterococcal endocarditis on either damaged or healthy valves. Another bacterial species is Streptococcus galolyticus, previously known as Streptococcus bovis, which is normally found in the gut flora. But when there's a colorectal bleeding, like with colorectal cancer, these gut bacteria can migrate across the gut lining and into the bloodstream, which can develop into endocarditis. A high yield fact here is to remember that in case of S. galolyticus endocarditis, we need to do a colonoscopy to look for colorectal cancer. An even more unusual bacteria is Coxiella burnettii, which patients typically contract after exposure to infected animals like cows, sheep, and goats. The bacteria initially causes a disease called Q fever, but the infection could be asymptomatic. What makes this hard to diagnose is that endocarditis can develop months or sometimes years after the initial infection. But usually this is in high-risk people, like those that are immunocompromised, pregnant individuals, and those with pre-existing heart valve defect, which makes it tricky to diagnose unless there's a reason to suspect it. The most commonly affected valves are the mitral and aortic valves. Next, a group of organisms associated with endocarditis are the Hasek organisms, which are gram-negative bacteria that are also part of the normal flora of the mouth and throat. Each letter of Hasek stands for a different genus: Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella. We used to suspect them as a major cause of infective endocarditis, but recent research has shown that they are only responsible for a very small number of cases. Finally, in really rare occasions, infective endocarditis can be caused by Pseudomonas species, or Bartonella species, both of which are gram-negative bacteria, or by fungi like Candida. Pseudomonas and Candida endocarditis are usually associated with intravenous drug use, in which case the tricuspid valve is most commonly involved, while Bartonella can be transmitted by cats. Okay, now from a clinical point of view, infective endocarditis can be classified into groups like acute and subacute based on how quickly the infection developed. With acute endocarditis, the infection develops quickly and it's most often caused by Staphylococcus aureus, while with subacute endocarditis, the infection has a gradual onset and it's most often caused by viridin streptococci. Now, people with infective endocarditis almost always have a fever, as well as a new heart murmur that results from turbulent blood flow past a damaged heart valve. Sometimes, those vegetations can detach from the valve to float through the bloodstream, and this is called septic emboli. Remember that a septic emboli from the left side of the heart can lodge in the arterial circulation of the brain, causing ischemic stroke, while right-sided ones can lodge in the pulmonary circulation as pulmonary emboli. More rarely, there might be a paradoxical embolus, which dislodges from the right side and then slips through an atrial septal defect, or patent foramen ovale. It enters the left atrium, and from there, it can head off to the blood vessels supplying the brain, causing ischemic stroke. Next, a couple of very high-yield signs. Septic emboli can also get stuck under the fingernails, causing splinter hemorrhages, or in the palms and soles of the feet, causing small, painless, flat, and erythematous lesions, called Janeway lesions. The pathogens can also trigger an immune reaction where the antigen-antibody complexes that form can deposit in different parts of the body. In the fingers and toes, these complexes can lead to painful red raised lesions called Osler's nodes. In the eye, these deposits can lead to Roth spots. For your exams, remember that sometimes these deposits can reach the kidney, leading to glomerulonephritis, in which case the individual may present with oliguria and high serum levels of BUN and creatinine. Diagnosis of infective endocarditis is based on the Duke's criteria, which take into account the clinical presentation, blood cultures for microbiologic data, and echocardiography. For your exams, remember that finding the cause typically involves getting multiple blood cultures. Next, remember that if the blood cultures are negative, then the culprit may be one of the following: Coxiella burnetii, Bartonella, a bacteria from the Hasset group, or fungi like Candida. Echocardiography can also be used to visualize the heart and look for vegetations or more subtle clues like abnormal valve movement. It's also important to prevent infective endocarditis, especially among high risk groups, such as people with prosthetic heart valves or a history of endocarditis. Before dental procedures, sometimes these people are recommended antibiotics, specifically amoxicillin. Remember, some of those microbes that cause endocarditis live in the mouth. Alright, as a quick recap, endocarditis is inflammation of the endocardium, which can affect the heart valves, the mural endocardium, or prosthetic valves. Endocarditis is usually due to a microbial infection, but in some cases it can also be non-infective. Non-infective endocarditis is caused by damage to the endocardium, which causes tiny blood clots that form vegetations on valves. And this is called non-bacterial thrombotic endocarditis, or NBTE. This can happen with hypercoagulable states, malignancies, or systemic lupus erythematosus. Now, in infective endocarditis, microbes reach the bloodstream and attack the endocardium, which usually affects the valves on the left side, especially the mitral valve. Remember, with IV drug use, the tricuspid valve is at risk. Infective endocarditis is usually caused by low-virulence viridin streptococci, which attack valves that have had some previous damage. Other causes include Staphylococcus aureus, which can affect damaged valves, and Staphylococcus epidermidis, which affects prosthetic valves. In Streptococcus galolyticus endocarditis, remember to check for colon cancer. Coxiella burnetii can cause endocarditis months to years after the initial infections. Next, remember that Hasset, Bartonella, Candida, and Coxiella are culture negative. Clinically, individuals present with fever, splinter hemorrhages, Janeway lesions, Osler nodules, Roth spots, and sometimes even glomerulonephritis. Blood cultures, as well as echocardiography, are needed for the diagnosis. And finally, back to our cases. Darren came in with a fever along with chills and fatigue. On the clinical examination, his fingernails had splinter hemorrhages and Janeway lesion. Both of these signs are consistent with endocarditis. Now, Darren also had some track marks on his forearms. This is consistent with IV drug use. Blood cultures showed that Darren had an infection with Staphylococcus aureus, and echocardiography showed that the tricuspid valve was damaged. So, Darren has infective endocarditis caused by S. aureus and associated with IV drug use. Then there's Anna, who came in with a fever and the same lesion consistent with endocarditis that Darren had. On auscultation, there was a heart murmur. Now, considering that Anna has a history of endocarditis, this means that her heart valves may be damaged. Blood cultures showed that Anna had an infection with viridin streptococci, which makes sense, since she said she had been to the dentist about 2 weeks ago. Echocardiography showed tiny vegetations in the mitral valve, so Anna has infective endocarditis caused by viridin streptococci, and in her case, infective endocarditis following a dental procedure.
Endocarditis means inflammation of the inner layer of the heart. The heart's wall is made up of 3 layers, the epicardium being the outermost layer, then the myocardium, and then the endocardium, which is the layer that gets inflamed. It turns out that most cases of endocarditis are due to a microbial infection of the endocardium. Any area of the heart that's exposed to turbulent blood flow, like a narrowed cardiac valve or a septal defect, could be affected by endocarditis. Turbulence of blood flow causes damage to the endocardial lining. That damage exposes the underlying collagen and tissue factor, which causes platelets and fibrin to adhere, which forms this tiny thrombosis or blood clot. This is called non-bacterial thrombotic endocarditis, or NBTE, and it's non-bacterial because it happens even before the bacteria shows up. Then a microbe has to get into the bloodstream, and that might happen if a person has an obvious open wound or an abscess, a dental or surgical procedure, or injection with an infected needle or infected substance, usually while using illicit drugs. The valves are often affected because they're often the site of turbulent blood flow. Most often the valves on the left side are affected, the mitral valve and the aortic valve, sometimes due to predisposing conditions like mitral valve prolapse and bicuspid aortic valves. Risk factors for developing endocarditis include having prosthetic valves, having a congenital cardiac defect, having damage to the valves from rheumatic heart disease, and finally, intravenous drug use can put valves at risk. Although most cases of tricuspid valve endocarditis are due to intravenous drug use, the majority of intravenous drug use patients with endocarditis have left-sided valvular endocarditis. Even without using intravenous drugs, there are other opportunities for microbes to get into the bloodstream, whether it's through brushing your teeth and having them slip into your gums, or having them slip in through your gut or lungs. Whatever the case, they regularly make their way into the body. It's not usually a problem though, because it's a small amount and can easily be killed by our immune system. But occasionally they float around in the blood for long enough to find an NBTE, which serves as a perfect location for them to attach to and set up an infection, called a vegetation. To attach to it, a lot of bacterial species use proteins on their surface called adhesins that let them stick to the valve as well as stick to each other. They also create an extracellular matrix around themselves, called biofilm, which allows them to literally stick together and form a large clump of bacteria that can behave like a colony. Usually these guys stick to areas of lower pressures, since it's easier to adhere. So let's take mitral valve regurgitation, where blood flows backward from the higher pressure left ventricle to the lower pressure left atrium. So in this case, vegetations will tend to form on the lower pressure atrial surface. Not only that though, they'll form on the edge of the opening, and this is because of the Venturi effect. The Venturi effect describes how fluid pressure decreases as it flows through a narrowed opening, while its velocity increases. So as blood forces its way through the opening, the pressure is lower near the edges. If the person had aortic regurgitation, meaning blood's going from the higher pressure aorta to the lower pressure ventricle, then vegetations would tend to be located on the lower pressure ventricular surface of the valve. Infective endocarditis used to be classified into groups, like acute and subacute based on how quickly the infection developed. But nowadays the key is to identify the microbial cause of infection and to treat it as effectively as possible. Viridans streptococci is the most common cause. Its virulence is low, it's found in the mouth, and they usually attack valves that have had some previous damage, usually resulting in small vegetations which don't destroy the valve. Staphylococcus aureus, on the other hand, is a highly virulent bacteria that can be found in the skin, and this guy can infect both damaged and healthy valves, often the tricuspid valve. Staph aureus causes large vegetations that can destroy the valve, and is the bacteria most commonly contracted from intravenous drug use. Next, we have Staphylococcus epidermidis, which is a bacteria that loves foreign prosthetic material, like prosthetic heart valves. One way that the bacteria gets into the body is at the time of heart valve surgery, and it literally sticks around on the valve. Another common point of entry into the body, though, is through an infected intravenous catheter. Both of these scenarios usually happen in a hospital, so this would be considered a nosocomial infection. Two other bacterial species are Enterococcus fecalis and Streptococcus bovis, which are both normally found in the gut flora. But when somebody has severe colorectal disease, like colorectal cancer or ulcerative colitis, these gut bacteria can migrate across the gut lining and into the bloodstream, which becomes a setup for potential endocarditis. An even more unusual bacteria is Coxiella burnetii, which patients typically contract after exposure to infected animals like cows, sheep, and goats. The bacteria initially causes a disease called Q fever, but months or sometimes years after the initial Q fever, they can develop endocarditis. But usually this is in high-risk people, like those that are immunocompromised, as well as pregnant women and those with pre-existing heart valve defects, which makes it tricky to diagnose unless there's a reason to suspect it. A group of organisms that are less commonly associated with endocarditis are the Hayseck organisms. These guys are a group of gram-negative bacteria that are also part of the normal flora of the mouth and throat. Each letter of Hayseck stands for a different genus: Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella. Finally, fungal endocarditis can also happen, but mostly in intravenous drug-using patients or patients in the intensive care unit on multiple antibiotics. It's important to remember fungi, as routine bacterial blood cultures won't grow them. Now, people with infective endocarditis almost always have a fever, as well as a new heart murmur that results from turbulent flow past the damaged heart valve. Sometimes those vegetations can detach from the valve, and little clumps of pathogens can float through the bloodstream, called septic emboli. These guys can lodge under the fingernails, causing splinter hemorrhages, or in the palms and soles of the feet, causing small, painless, flat, and erythematous lesions, called Janeway lesions. Separately, there might be an immune reaction, with antigen-antibody complexes that form and deposit in different parts of the body. In the fingers and toes, these complexes can lead to painful lesions called Osler's nodes. In the eye, these deposits can lead to Roth spots, and in the kidney, they can lead to glomerulonephritis, or inflammation of the glomerulus of the nephron. Diagnosing the cause of infective endocarditis typically involves getting multiple positive blood cultures, which is literally growing bacteria from a blood sample. Echocardiography can also be used to visualize the heart and look for vegetations or more subtle clues, like the way the valve's moving. Depending on the organism that caused the infection, a prolonged course of antibiotics will likely be used to try and wipe out the infection, but surgery might be needed for severe cases, especially when the valve dysfunction causes heart failure or there are multiple emboli. It's also important to prevent endocarditis, especially among high-risk groups, like for example those with prosthetic heart valves, history of heart transplant, and a history of endocarditis. Before dental procedures, sometimes these people are recommended antibiotics, since remember that some of those microbes that cause endocarditis live in the mouth. Finally, there's Liebman-Sachs endocarditis, which is not infection-related. This one's usually associated with systemic lupus erythematosus, which is an autoimmune disease involving antigen-antibody complexes. And in this case, they settle in the endocardium and cause inflammation. These areas of inflammation can happen anywhere on the valve surface or chordae tendineae, but typically happen on the mitral valve, leading to mitral valve regurgitation. In this case, inflammation can also happen on the atrial endocardium or ventricular endocardium. Alright, as a quick recap, endocarditis, or inflammation of the endocardium, typically develops from bacterial infection. Usually in this case, there's first some damage or injury to the heart valves, which leads to thrombi, which serves as a place for bacteria to adhere to and cause inflammation. Sometimes, though, it can be non-bacterial. One example being Liebman-Sachs endocarditis, which is associated with lupus, an autoimmune disease.
With myocarditis, myo means muscle, card means heart, and itis means inflammation. So, myocarditis is inflammation of the myocardium, which is the muscular middle layer of the heart wall, which contracts and relaxes so the heart can pump blood all around the body. Inflammation in the myocardium layer causes swelling, and that damages the heart muscle cells' ability to contract. That means that less blood gets pumped out of the heart with each heartbeat. And if myocarditis is severe enough, it can lead to heart failure, which is when the heart can't keep up with the demands of the body. Once the inflammation resolves, the heart contraction typically returns to normal, but occasionally, when the inflammation is really severe, it can cause fibrosis or scar tissue in the myocardium. Scar tissue doesn't contract normally, so if that happens, it can cause long-term problems with heart contraction. In North America, viral infections, specifically Coxsackie virus B infections, are the main cause of myocarditis. Viral infections can trigger lymphocytic myocarditis, which is when lymphocytes, the B and T cells of the immune system, and water make their way into the interstitial space, the space between heart muscle cells. There are plenty of other infectious causes as well, though. One of these is Trypanosoma cruzi, a single-celled protozoan that causes Chagas disease throughout South America. In Chagas disease, under a microscope, it's possible to see groups of amastigotes within the heart muscle cells, which are trypanosomes that are in the intracellular stage. As a result, the heart muscle cells necrose or die. There's also Trichinella, a roundworm that moves from the intestines into various parts of the body, causing a variety of problems, including myocarditis. Myocarditis can also be seen in Lyme disease, which is caused by the bacteria Borrelia burgdorferi, which is spread by deer ticks. Finally, in immunocompromised individuals, there's Toxoplasma gondii, a single-celled parasite harboured by cats that can cause myocarditis. So, those are the infectious causes, but there are also non-infectious causes of myocarditis as well. These include systemic lupus erythematosus, also known as lupus, and polymyositis, which is a generalized inflammation of the muscles where the immune system starts to attack the myocardial layer of the heart. There's also drug-associated myocarditis, which means there's an adverse drug reaction that inflames the heart. Drug reactions cause a hypersensitivity myocarditis, which is when eosinophils get into the blood vessels in the myocardium. Finally, there's giant cell myocarditis, which causes inflammation in the heart from an unknown cause. The key finding here is that macrophages, the immune cells that engulf foreign substances, start to fuse together to form a single giant cell, hence the name. Individuals with myocarditis can have a chest pain that is sometimes positional, meaning that it can get better or worse depending on the body's position. It can also cause arrhythmias or irregular heartbeats because the inflammation affects the pacemaker cells travelling through the myocardium. There can also be more general symptoms like fatigue, fever, and shortness of breath. In severe cases, when myocarditis starts to develop into heart failure, there can be additional symptoms like fluid retention in the feet and ankles. Individuals with myocarditis suffer heart muscle damage, which causes troponin and creatine kinase levels to rise on blood tests. An electrocardiogram can show sinus tachycardia, a fast heart rate, as well as T-wave inversions and saddle-shaped ST segment elevations, because it looks a bit like a horse saddle. In addition, a chest X-ray might show an enlarged heart, while echography might show inflamed heart muscle walls. Ultimately, the diagnosis is based on a biopsy of the cardiac muscle, but doing that procedure comes with some risk, so it's not always done. The treatment of myocarditis depends on the underlying cause. Viral myocarditis usually improves slowly over time, and other infections are treated with appropriate antibiotics. If there are signs of heart failure, then they are typically managed with a medication and careful fluid balance. Arrhythmias usually resolve as the inflammation improves as well. Finally, in severe cases, like some cases of Chagas myocarditis and giant cell myocarditis, a heart transplant may be needed if other treatments don't work. Alright, as a quick recap, in North America, myocarditis is most often caused by viruses like Coxsackie. But in South America, a common cause is Chagas disease. Symptoms include positional chest pain and arrhythmias, and classic ECG findings include sinus tachycardia with saddle-shaped ST segment elevations and T-wave inversions.
Rheumatism is used to describe inflammation in the joints, the muscles, and the fibrous tissue. So, rheumatic fever is a type of inflammatory disease that can damage the heart tissue and lead to rheumatic heart disease. Rheumatic fever develops after streptococcal pharyngitis, inflammation of the throat due to Streptococcus pyogenes, where pyogenes literally means makes pus. The bacteria is sometimes referred to as group A beta hemolytic streptococcus, and the infection itself is most often just called strep throat. This particular group of streptococcus has an antigen that lumps it into a group called group A, and it also produces an enzyme called streptolysin that completely lyses nearby red blood cells, or causes them to rupture. Rupturing red blood cells is called hemolysis, right? And when those red blood cells rupture and are destroyed, it's called beta hemolysis, as opposed to alpha hemolysis, where cells aren't actually destroyed, they're just damaged or bruised. Some of these strep bacteria have a protein on their cell wall called M protein, and this particular protein is highly antigenic, meaning that the immune system sees it and recognizes it as a foreign molecule, and mounts an immune response, which, rightfully so, produces antibodies against these proteins. Those antibodies, though, are thought to cross-react with proteins on some of our body's own cells, like cells in the myocardium, or heart muscle, and heart valves, but also cells in the joints, the skin, and the brain. This phenomenon, where antibodies accidentally target proteins on our own cells because they look like the proteins on foreign cells, is called molecular mimicry, and is an example of what's called a type 2 hypersensitivity reaction. Once bound to cardiac tissue, the antibodies activate nearby immune cells, which causes a cytokine-mediated inflammatory response and tissue destruction. Obviously, though, not everyone that gets strep throat gets rheumatic fever, right? And it's actually only a small minority that get it, estimated around 3%. And it's more likely to happen with children or people in areas of poverty and crowding. A lot of patients that do get rheumatic fever from strep, sometimes called acute rheumatic fever, will have a variety of clinical findings. The most common of which is migratory polyarthritis of the joints, where multiple large joints become inflamed, swollen, and painful, one after another, although this damage isn't permanent. Secondly, some patients have pancarditis, or inflammation of all three layers of the heart tissue. The first, or endocarditis, is inflammation of the inner lining, which includes the valves. The mitral valve is most commonly affected, although the aortic valve might also be affected. The next is myocarditis, inflammation of the myocardium, or heart muscle. Inflamed area in the myocardial tissue are called Aschoff bodies, which are areas of fibrinoid necrosis with immune cells like T cells and these characteristic Anichkow cells, enlarged macrophages which have characteristic caterpillar-looking nuclei. It turns out that myocarditis is the most common cause of death in acute rheumatic fever, because this inflammation and necrosis makes the heart wall unable to contract with full force, which results in heart failure. Finally, there's pericarditis, or inflammation of the outer covering of the heart, called the pericardium, which can cause pain as well as a friction rub from the inflamed visceral pericardium rubbing against the inflamed parietal pericardium, which can actually be heard with a stethoscope. In addition to joint and heart problems, the hypersensitivity reaction in rheumatic fever can affect other tissues as well. Patients can develop subcutaneous nodules, these firm lumps under the skin made up of collagen. They might also have erythema marginatum, this reddish rash that shows up as rings on the arms or the trunk. Also, they could have synonyms chorea, which is a set of rapid movements of the face and the arms, from an autoimmune reaction against the basal ganglia of the brain. And this one typically won't appear until late in the disease, at least 3 months after infection. These 5 signs constitute the major diagnostic criteria for rheumatic fever, which are known as the Jones criteria. The Jones criteria also includes having a blood test that shows evidence of previous streptococcal infection, since these symptoms usually don't show up for 2 to 3 weeks after streptococcal infection. Finally, there are also some minor criteria that can help make a diagnosis, things like fever, joint pain, having more white blood cells in the blood than usual, elevated acute phase reactants, which are proteins that increase in the blood in response to inflammation. During inflammation, fibrinogen causes red blood cells to stick together. These clumped up red blood cells fall to the bottom of the test tube faster, called the erythrocyte sedimentation rate, or ESR. So someone might have an increased ESR. Finally, due to heart-related symptoms, they might have changes in their electrocardiogram, or ECG. Acute rheumatic fever usually resolves with rest, anti-inflammatory treatment, and maybe antibiotics like penicillin to wipe out any strep that's hanging around in the throat. It's worth mentioning that some patients might only have a subset of symptoms, in which case they might be classified differently. For example, post-streptococcal reactive arthritis includes patients with joint symptoms, and pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or PANDAS, includes patients with neuropsychiatric symptoms. If repeatedly exposed to group A beta hemolytic streptococcus, though, the body continues to launch immune attacks against the various tissues, but most notably the heart tissue, which can lead to chronic rheumatic heart disease. With chronic rheumatic heart disease, the valves, typically the mitral valve, but sometimes the aortic valve, develop scar tissue from repeated inflammation. The leaflets of the valves become thicker and can actually fuse together, called commissural fusion. Also, the chordae tendinii, which are attached to the valves, can become thickened as well. These changes can cause complication with the valves, most commonly regurgitation, meaning that they don't close all the way. This can progress to stenosis, or narrowing of the opening, sometimes called fish mouth stenosis or buttonhole stenosis. These roughened areas are also at higher risk of microbial attachment and invasion, called infective endocarditis. Since recurrent attacks of acute rheumatic fever leads to chronic rheumatic heart disease, a major goal is to prevent these attacks of acute rheumatic fever, so essentially reducing recurrent streptococcal infections. So depending on the severity of symptoms and damage to tissue, patients might receive prophylactic antibiotic treatment for long periods of time, from 10 years to life. Amazingly, resistance to group A strep to penicillin hasn't been a problem after more than 50 years of extensive exposure. Alright, as a quick recap. Rheumatic fever can develop after a group A streptococcal infection, like strep throat, due to antibodies against streptococcal M proteins that cross-react with proteins in the myocardium, heart valves, joints, skin, and brain. It's characterized by the Jones criteria, which involve migratory polyarthritis of the joints, pancarditis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. Recurrent attacks of rheumatic fever can lead to chronic rheumatic heart disease, which most commonly causes regurgitation in the mitral or aortic valves, but can also cause stenosis. Treatment involves anti-inflammatory medications and prophylaxis with penicillin.